Pleasure to introduce Dr. Karam Al-Jumaily. He's one of our sleep medicine fellows here at Yale. Dr. Al-Jumaily completed his medical degree at University of Sharjah and went on to train in Canada, including in internal medicine in Calgary and Alberta, followed by adult respirology fellowship at Dalhousie University, where he served as chief fellow. He later joined their faculty as respirology attending before coming to Yale. At Yale, he was a postdoc and has been involved in clinical and translational research in interstitial lung disease and pulmonary fibrosis. Within sleep medicine, he has contributed to ongoing work examining insomnia, sleep apnea, and metabolic outcomes in veterans. With to Sleep 2026 and ATS 2026. So without further ado, I leave it to Dr. Al-Jumaily.
Thank you very much, Dr. Wojak, for your kind introduction. And thank you very much for mentoring this session too. So as Dr. Wojak said, my name is Karam, I'm one of the sleep fellows, and I'm here to talk about the sleep disorder, breathing, and diabetes. And it's a very big topic, and I try to see what evidence we have about this topic. So this is the CME slide with the number to call, number to text, and I think they also send it through chat during the presentation. These are my learning objectives, which is basically try to understand the relationship between sleep disorder breathing and diabetes. Also going to talk about the role of obesity as confounder. Also going to talk about the mechanism linking sleep disorder breathing and diabetes. And eventually, at the end, we'll talk about the data on treatment of OSA with CPAP and its effect on diabetes and glycemia. So you don't need to look at the slide to know that diabetes is a big problem. We know it's a highly prevalent disease. We see in inpatient and outpatient the complication of this disease, and what this slide tells you basically that according to the International Diabetes Federation, these numbers are only going to go up, and the expectation that diabetes prevalence is going to increase. So, as a sleep doctor, the question is, what are the prevalence between sleep disorder breathing and diabetes? How often they co-occur? And I'm going to start talking about like big studies, big data, try to see about the prevalence in both of them, and then try to go to more prevalent data. So this is a big study. It's a systemic review and meta-analysis of 19 studies across 18 countries. Basically, they looked at the cross-sectional, what are the association of type 2 diabetes and OSA or prevalence in patients. This was multiple continents, 18 countries, and in this article, the criteria for diagnosing OSA was either an AHI of 5 during sleep test, and these are the device studies, and or the using questionnaire. So use like a stop bank questionnaire, and if you score more than 2, you're positive. But they stratified the results also by device versus questionnaire. And the type 2 diabetes diagnosis was confirming the diagnosis of diabetes by physician, plus the patient should be on hypoglycemic drug. And despite all of that, restriction in this criteria, there's a high prevalence. The pooled OSA prevalence is 56% of OSA prevalence in type 2 diabetic patients. And it ranged between 50 to 90. It's increased risk in patients with higher BMI, older age, and male sex. And if you look at the stratified data, probably can convince yourself that the device data probably more favorable result, more positive than the questionnaire. In general, this is interesting data, shows some correlation, maybe some factor driving this prevalence, which is BMI, male, or age, but I don't think there's anything specifically new in this data. It just tells you they're prevalent. Now, if we want to go more granular, this is the forest data from Sleep Ahead. So Sleep Ahead is an ancillary data from the Look Ahead. Look Ahead is like a 5,000 overweight and obese patient with a BMI above 25, and they had like a 16 site with multiple lifestyle intervention. The Sleep Ahead is an ancillary study nested inside the big study, and basically four of those 16 sites recruited a 305 patient. So it's not a secondary analysis, it's actually like an ancillary part. And they did a sleep test on them. Those all type 2 diabetes patients. It's not clear if they're all patient obese, because the big study had included overweight and obese. In this specific study, they used the word obese, but they never used a cutoff. So we know they at least above 25 using the criteria from the large study. But they're again they use the word obese. So and the average BMI in the study was 36. So they found on this study that the OSA prevalence, they all had sleep study, and the OSA prevalence in type 2 diabetes obese patients is 86% undiagnosed OSA. One third is mild, almost one third is moderate, and one fifth has severe. So it kind of tell you, it is actually more prevalent, and more granular data in the study showed that if you go up 10%, you increase the odd of OSA diagnosis, AHI above 5 or 5 and above, with increased by 1 centimeter in waist. And you increase the chance of severe OSA, diagnosed in AHI above 30, with by 10% with every increase by one BMI unit. The next circumference data were not predictive. So all these studies basically kind of paint a story that obesity may be driving the OSA diabetes link. So we know OSA linked with obesity, and we know that diabetes also linked to obesity. So the question is it just obesity trials, or there's anything else driving it? And we actually have a data for that. There's a local data here from the VA in Connecticut. It's by Nader Butros, one of our previous fellows, and Dr. Yagi was part of the study too, where they looked at the cluster of 544 VA patient, and the definition for the study, they defined them by quintile. So quintile 1, 2, 3, 4, and you can see in the green side what this quintile means. So the reference group, the normal group, is AHI less than 8. So for the purpose of the study, the control group or have no OSA, let's say for example, is an AHI below than 8, not 5. Quintile 2 is 8 to 20, 3 is 21 to 45, and 4 is above 46. And you can see it's a typical VA data, like male uh, on the older side, 50s to 60s, and most of them maybe not sleepy, like 7 to 8 on the cutoff of having sleepiness. And the AHI goes, of course, higher with the quintile because that's how they're defined. And this is very interesting data because they also matched for BMI. So now we can actually try to get the obesity part out of it. And you see here, even the adjusted data for BMI and actually multiple other variables, the adjusted hazard ratio is 43. So there's a 43% increased chance of incidence of diabetes in OSA patients. And you have the diabetes-free survival, where the Kaplan-Meier curve, which shows basically is the sleep apnea group, which is defined in AHI above 8, with time have increased risk of incidence type 2 diabetes. The mean duration follow-up for this study is 2.7 years from the baseline, which is the index sleep study time. They also had data, which I'm going to go more about RCT talking about it, but just because we talked about the study, they also looked at CPAP, and they found out with the regular CPAP use, which wasn't clearly defined, it's two physicians blinded to the outcome, looked at the charts, and they defined them either regular use versus non-regular use, but I'm not sure exactly how many hours by that. But people who end up in the regular use, the OSA patient, end up have less incidence of type 2 diabetes compared to the control. But they use the upper two quintiles for the study. So AHI above 20. Those are the quintile 3 and quintile 4 compared to the reference group. And I'm going to talk about more in depth about the CPAP RCT data in the end of this presentation. So what else? What other information we have about diabetes and OSA? So this is a big cohort. Try to answer a question about the prevalence of type diabetes in sleep disorder breathing, and looking at the severity of sleep apnea and glucose and A1C. So a little bit more granular data here. And as you can see in this data, they define them by no OSA, mild, moderate, severe. The caveat here, I would say, their definition of severity is ODI. Because at the time for the study, which is published in CHEST 2014, lots of the European studies, like 24 sleep clinics across 15 countries and Israel, and they found out not a lot of those centers at the time using the ASM criteria, so they use actually an ODI data. So, oh, no OSA is less than 5, mild is 5 to 15. So the same number as 15 to 30 and severe above 30. And again, it's heavily male, 90% white because European data, a lot of them are obese. And basically looking at more granular data with, again, it's a cross-sectional study. And what they found out that if you look at the type 2 diabetes prevalence, it goes higher with severe ODI, which is a statistically significant result. Also, if you look at the, sorry for this, maybe it's not clear. This is the adjusted mean HbA1c, and it looks like the mean HbA1c actually goes higher, 6.066 with severe, or it's basically more than 30 ODI index compared to the no OSA. So there's a statistically significant result that severe ODI and could increase in prevalence of type 2 diabetes and HbA1c. But I have so the question is, why should we care? Like, how important is data? We know OSA. Now we cannot prove that OSA and diabetes are too prevalent together, but why this is important? And the importance come partly from this study. They looked at OSA as a risk factor for cardiovascular and microvascular disease in patient with type 2 diabetes. So basically, this is a diabetic patient, and they looked at OSA as a risk factor for multiple cardiovascular risk factor. So having the OSA and diabetes together, will it affect your cardiovascular risk factor? And they looked at a lot of risk factors. So they started from, as you can see, it's a 782 general practice in the UK. And they looked at patients with type 2 diabetes, and they stratified them. Do you have a history of OSA after type 2 diabetes or OSA before type 2 diabetes? They looked at both of them. So there's a cohort who have started with OSA and end up having an incident diabetes down the line, or the other way around. And they looked at cardiovascular data, which from CVD, ischemic heart disease, heart failure, stroke, etc. And as you can see, so just for clarity, the incident OSA is basically our diabetic patient having an incident of OSA in the exposed part. The prevalent OSA are OSA patient having and the exposed part is the type 2 diabetes. And again, mostly male, and they're in the 50s and 60s. We saw from previous uh, trials. And where's Moses? Okay, so looking at the cardiovascular outcomes, clearly, if you look at the composite cardiovascular disease, both if you look at the incident OSA or the prevalent OSA data, there is increased risk there. Lots of when you compare the incident OSA to prevalent OSA, you see that the incident OSA end up being statistically significant. So ischemic heart disease, heart failure, uh, um, uh, stroke and TIA, AFib, mortality, and there's also microvascular outcomes too. So this data tells you when you have these two together, you probably have increased risk of cardiovascular, either a big cardiovascular outcome or microvascular outcomes, including mortality. But it seemed to be from this data that if you do have a history of diabetes and then end up having an OSA, may be worse. But in general, these two, when they go together, they're not good. So I kind of talked about these studies where there's a high prevalence, maybe even more prevalence in obese patient. Even if we controlled for BMI, there's a 53% incident increase. But the question is, most of these studies are not weight controlled, or even if they match for BMI, the actual patients are actually obese. Their BMI average mean is 30 plus. So the question is, did we look at the pathway? So obesity, we know it leads to OSA. Obesity knows to need to cause an insulin resistance, and most patients with OSA are obese. Most patients type 2 obese. So how do we know for sure there's an actual connection between sleep disorder breathing and diabetes, and not obesity driving the whole thing? And maybe this is the whole thing is obesity, and we need to focus on weight loss, and that's it. So the question is, does the finding hold in lean OSA data? And the answer is yes. We have the study. It's a small study, but it's like a young, lean volunteer with no cardiometabolic disease. So like 18 to 30-year-old, BMI 18 to 25. The controls were matched for age, BMI, ethnicity, and family history of diabetes, and the OSA defined an AHI above 5. Now, so I just need to move my mouse here. So as you can see, despite having similar area on the curve glucose, the insulin resistance is higher in the OSA population, and the insulin sensitivity is lower in the OSA population. So basically, that tells you that it's probably not obesity. Maybe there's else. It could be part of the story for sure, but it's not the main. It might not be the main driver. And there's probably other drivers that linking OSA to metabolic outcomes because this is a very young data. And again, lean patients, no cardiometabolic disease, but you still have the same effect on glucose. So the question is, what is the mechanism? What's driving what's the link between OSA and this metabolic outcome? So, trying to find the mechanism, there's this paper we're trying to look at multiple mechanisms like circadian alignment, short sleep duration, OSA. I would say each one of these three is a ground down by themselves. But my focus today is OSA, and we're going to talk about the biggest link, the intermittent hypoxia, and some talk about sleep fragmentation too. The thought at the time is the reason these things work and cause, the intermittent hypoxia and sleep fragmentation to insulin resistant is basically by sympathetic activation, cortisol, oxidative stress and reactive oxygen species, inflammatory pathway, and adipokinase. Probably adipokinase is an obesity mechanism, but these three are not. The question is, can we there's any way to know if intermittent hypoxia itself can cause that, or it actually go through those mechanisms and lead to insulin resistance? How we can separate the two? So there are studies for that, and we'll start with the first one. This is a very interesting study. I would say it's a mice data where basically they looked at lean male mice and they cycled down the hypoxia 5 to 6% and 60 times per hour for 9 hours, and then left them for like 48 to 72 hours for recovery. They were conscious, they were unrestrained, and they did something called a euglycemic clamp. There's multiple clamps for this trial called the euglycemic clamp, and it's kind of confusing in the beginning. It's kind of counterintuitive, but what they do is they give mice insulin and in fixed rate, which is in this case 20 millunits per kilogram per minute, and they titrate the glucose to reach euglycemia. And what confuses here is if the mice had normal insulin sensitivity, they're normal mice, they probably need a lot of glucose to reach euglycemia. So you need to give them more glucose because they have insulin too. Now, if the mice has insulin resistant, probably the insulin you're giving them is less effective. So you need to give them less sugar. So it's kind of confusing, but if you need to give a lot of glucose to reach euglycemia, probably you're insulin sensitive. If you need to give less glucose, you're probably insulin resistant. And I'm going to explain this more in the next two slides. So they not only looked at euglycemic clamp, they looked at muscles uptake, like slow twitch, mixed fiber, and fast twitch to see if the muscle get affected with this intermittent hypoxia. And the most interesting part of this trial is the ANS blockade. They blocked the autonomic nervous system. And the idea is if we blocked it, and they had an efficacy test to confirm that they blocked, if we block it, will the effect goes away? Because if the theory is it's intermittent hypoxia work through sympathetic activation, and we block the sympathetic activation, the effect should go away. So what happened? In the intact autonomic nervous system, there was a 21% reduction in insulin sensitivity. So they both reach euglycemia, both type of mice, the control and the intervention arm. And you can see here in the glucose infusion, the dark square, they needed less glucose to reach euglycemia than the normal or control mice. And the reason is they're actually more insulin resistant. So they needed less sugar. The control mice, they have no problem. Their insulin sensitivity is presumably normal. So the insulin was effective decreasing their glucose. So they needed more sugar. So this is how they found, and they found basically it's a statistically significant result that those mice with intermittent hypoxia had more insulin resistant. Now, what happened after they blocked the ANS? And the answer is result became even more wide. The difference became more wide and became more statistically significant. It became 29% reduction. The answer for this is not clear. It was a surprise to the author, and there's no exact mechanism could explain this. But what this slide argue against, that the catecholamine surge is not the sole mechanism. Intermittent hypoxia could be through other ways or by itself can actually lead to change in your insulin sensitivity. And just to complete this trial, when they looked at the muscle data, the oxidative muscle, the slow twitching, had decreased glucose uptake compared to the fast twitching or glycolytic data, which kind of makes sense because how these muscles work. Uh, then some people looked at other mice data and they looked at persistent damage after recovery. So it's the same thought, same clamp, but what they did in this case is they looked 7 days after the event, the intermittent hypoxia, and they had 7 days fully of normoxic recovery. And despite those, this time of normal oxygen, they still have increased glucose increase and worsening glucose tolerance. So this kind of suggests these effect could actually last longer. It's not like a one night. How about human data? What do we know about human? And the answer is we have this study from Punjabi and Lewis from John Hopkins. What they did is they put this patient on, they caused hypoxia. They're all lean. They're all healthy volunteers. And what they did is they give them an FiO2 from 21 and they drop it to 5 and then go up and down. The SpO2 drops from 97 to 77. So they basically induce intermittent hypoxia. And they start at 8:30. They start infusing glucose at 1:30 p.m. and then they end the protocol at the end. And what is the result? Same thing, same the mice data. Your insulin sensitivity goes down, your glucose effectiveness goes down, and they're all statistically significant data. So the question here is, do we have a bigger data? We talked about mice, we talked about small human data. How about a larger study looking at specifically nocturnal hypoxia and incident type 2 diabetes? And the answer is we have a study from Japan. They had a prospective community cohort, 4,000 plus adults. The follow-up means 3 years, and the actual retained follow-up is 92%. They divide them by ODI category, not AHI, like less than 5%, 5 to 15, and more than 15. And the outcome we're looking for is the incidence diabetes, like more than 7 millimole, either fasting glucose 11.1 for the random, or you started any medication. And they actually adjust for a lot of variables, including BMI, waist, and sleep duration. And if you look at the data, as you can see here, when you divide those by ODI, looking at the model 2, which basically again adjusts for age, BMI, community, smoking status, alcohol intake, borderline diabetes, single night sleep duration, and for women menopausal versus premenopausal, and matching for all this, adjusting for all this, the data came back positive. So patients who have a high 3% ODI, like more than 15, there is increased incidence of diabetes. And the p-value was also positive for trend. So the higher ODI category, the more likelihood you have incident diabetes. Now, this is in red. This data is non-statistically significant. If you look at the SpO2, even if you go below 83%, the data became still not significant. So it's not the SpO2 nadir. This data kind of tell you this is the ODI itself, the intermittent hypoxia. It has an effect with incident diabetes. And where are we? I'll try to find an explanation and why this happened. So briefly going to talk about one of the thoughts, and this is not my area of expertise, but in basic science data, they looked at if you induce cyclical hypoxia regeneration, and the HIF1A gets more, which is basically a pro-oxidant enzyme, and the HIF2 alpha, which is an antioxidant, goes down. So the pro-oxidant go up, and the antioxidant goes down, double whammy, and you have a massive reactive oxygen species surge. That's one of the theory, but I don't think this is completely proven. So we talked about intermittent hypoxia. How about sleep fragmentation? How does that get in the mix? And the question is, we know OSA can cause both, there's any, there's any data that looks at arousals versus hypoxia. Is the glycemic effect affected by arousals or hypoxia? Because if it's arousals, you could argue that this is a cortisol catecholamine surge mechanism. If it's hypoxia, then it's just hypoxia, right? And we do have a study from the DREAM study, which is actually our also local study. It's by Dr. Brian Wojak, Dr. Yagi, and Dr. Zinchik. So from our group. So as you can see here, I'm trying to, if you can focus on the arousal and poor sleep versus the hypopnea and hypoxia. So the arousal group was, after adjustment, they were not statistically significant for incident type 2 diabetes in OSA patients. But the hypopnea hypoxia was, and actually it's statistically significant, and the hazard ratio is 3.182. So it's like increased the risk of type 2 diabetes by almost 3 times. So this kind of give credence to the idea that, well, probably hypoxia is the mechanism more than anything else. Probably the other mechanism has some contributory effect, but seemed to me, putting all this information together, the hypoxia might be the driving factor here. So quickly, I'm going to brush about other mechanism. So we know that with arousals, you have a sympathetic overactivation and catecholamine surge, and we know about the effect of alpha adrenergic and beta adrenergic effect on gluconeogenesis. How about sleep fragmentation itself? There's any data about that. So there is data about sleep restriction and fragmentation. My focus today is fragmentation because that's more related to OSA, but I will say there is data out there about sleep restriction. So, they found out that with this low number of patients, if you restrict those patients, if you fragment their sleep, you actually could lead to worsening insulin sensitivity. So again, talk about one of the trials, which I found very interesting. It's the 3 nights of slow wave suppression. Um, so this is by Dr. Tisali in Chicago. So what she did is they basically wanted to prove that stage 3 suppression. So we're only going to suppress at the time of this published. It's what they're calling it stage 3 and 4. Which we now, in the new guidelines, stage 3, basically the slow wave staging. If we suppress that, which we know get affected a lot with arousals, and we see this in our split studies when we have a patient on diagnosis have no N3, and then the moment we put them on CPAP, they start having N3. So we know OSA have arousal and probably have some effect on stage 3 sleep. What she did is, and I know this data is confusing because she used the word N1, N2, and 3. Here it means night 1, night 2, night 3, not stages, by the way. So at baseline, the patient had total sleep time. They suppressed the slow wave by delivering acoustic stimuli by variable frequency every time you go to stage 3. Basically, they just want to stop stage 3 from happening. They kept the total sleep time the same. So you see these 3 nights have the same total sleep time. These 3 nights had the same REM. And of course, they have much less stage 3 because that's what they're trying to stop. And the N3 went up because I guess that time went to the N3 that you dropped from the stage 3. So this data with they're actually lean volunteers and healthy volunteer, despite keeping the total sleep time the same, the REM time the same, and the N3 went up, but basically the slow wave went down. Those patients after 3 nights of suppression had decreased glucose tolerance and decreased insulin sensitivity. So this is also more data we have that sleep fragmentation itself, which is I think that's OSA usually does, can also cause insulin sensitivity. So yeah, they're all lean volunteers, and the insulin sensitivity went down by 25%. There were 9 healthy learn volunteer. And Dr. Tsali in her notes says in the article, and she had a YouTube video about that too, saying that we gave people in their 20s the sleep architecture and those in their 60s. And we basically, those probably relevant to OSA patients because, they probably have the same architecture. So And at the end, I was going to talk, before I talk about clinical trial data, I was going to say that I was looking for any data about, insomnia or sleep fragmentation and sleep apnea. There's this term which was starting to get more and more in the literature called COMISA. This gentleman, Dr. Sweetman, actually the person who coined that term, the comorbid insomnia and OSA. And he had this theory that he published about how the OSA cycle and the insomnia cycle together, and each one kind of lead to the other. And the patient with OSA can end up having insomnia and vice versa. There's some kind of a bidirectional relationship. I just want to say he have this theory, which I can explain the next slide. Oh, now it's working. So he have this like four phenotype of patients. So let's say you don't have no insomnia and no OSA. You have the best sleep. Then you have these patients who have insomnia but no OSA. They take longer to fall asleep. They're hyperarousal, but there's no ventilation issue. Type C is, or this figure is, if you have OSA only patient where every time they have a vent event, they wake up, then they sleep very quickly because they're not hyperarousal. The question is, we have this COMISA type where you are insomniac, take a long time to fall asleep, you have this respiratory event because of the OSA, and then you wake up, and because you're hyperarousable, you might stay awake a little bit longer, and then you go back. The question is insomnia and OSA is just like 1 + 1 = 2, or does the COMISA patient actually have some kind of amplification effect? They actually do even worse what we expect from insomnia and OSA patient. And I don't have the result for you today for the answer for this question, but the group I work with, Dr. Zinchek, Dr. Wojak, and Dr. Gaffey, we have some working and interesting data about insomnia, sleep apnea, and COMISA in the VA population, and we're trying to find out if there's any multiplication effect or there's any difference in those three phenotypes leading to the incidence of diabetes. So this is going to be, we're going to publish the abstract in the Sleep 2026. Other proposed pathway, I'm going to again quickly talk about them. So there's a systemic inflammation pathway, there's a cortisol pathway, but all these studies, unfortunately, most of them did not actually they were confounded for obesity. So really, it's difficult to say if those, how much of a major factor there is. There's also talk about gut microbiome. So they found out that hypoxia mice had change in their microbiome gut, and there's a thought maybe using a probiotic could partially reverse the induced hypopnea, induced vascular dysfunction. Again, this is like outside of the realm of this presentation, but it's like an early active area of research, preclinical data, but there is data there, and you might see more in the future. So we talked about these mechanisms. The question is that we know it's bad, we know it's prevalent, we know the sleep fragmentation, intermittent hypoxia cause change in your insulin. Is there any data talk about treatment with CPAP and looking at HbA1c, glucose, or incidence of diabetes? And the answer is yes. So we have this first data. They basically looking at the OSA type 2 diabetes population, and it's a European data, and they will basically a systemic review trying to find out if you give patients CPAP, those diabetic OSA patients, does that change in their A1C and fasting glucose? If there's any treatment effect, basically. So basically, they had multiple RCTs. You have to have an RCT design, 18 years and older, AHI above 5 at least, and type 2 diabetic, which is defined by A1C more than 6.5. So these are the studies. They end up having 11 RCT, and these are the RCTs. So as you can see, the AHI is like 15, 10, 5. Some of them has CPAP versus no CPAP. Some of them have a sham CPAP, which is basically is like subtherapeutic, or like 0.5 or 1 centimeter of CPAP. And the result came back positive. So if you see this forest plot, it came back positive that the A1C decreased by 0.24% of mean HbA1c. And even they saw there's an effect with nightly CPAP use. So the more CPAP you use, especially close to the 7-8 hours, the more increase you have in the HbA1c reduction. So it's not like an on and off, you use CPAP versus don't use CPAP. There is some, data shows that longer CPAP use could affect your HbA1c. Which that what slides shows. So how about data specifically looking at, CPAP, a specific RCT, looking at that? And the answer is we have the SAFE trial. It's a multinational data. They gave CPAP for all patients with uh, uh, they gave it to a diabetic patient, they gave it to a pre-diabetic patient, and they gave it to a normal patient who are not diabetic and no diabetes. And they tried to give all CPAP versus no CPAP and see if there is any difference. So it's a huge data. I'll say one more thing about this before I show the table one. They excluded the sleepy patient, so the Epworth was less than 15 to qualify for the study. Also, they excluded the severe nocturnal hypoxia, defined by SpO2 less than 80% for more than 10% of the night. So they took off the hypoxic patient and they took off the sleepy patient. And in a way, they might have shot themselves in the foot when they did that. So this is the population. It's a huge population. There's a non-diabetic population, pre-diabetic population, and neither. And they just divide them usual care versus CPAP. And they're not sleepy, as you can see. They're 9 and 8. They and what else? As lots of them had the cardiovascular, because the thought is, are we able to decrease cardiovascular outcome? This is what that was not looking specifically on glucose and diabetes, looking at a lot of cardiovascular outcomes. For the certain of today's talk, I'm just going to talk about the diabetes part, but they're basically a cardiovascular risk factor patients. Now, unfortunately, the result did not come back as we might expect. So as you can see here, the data for neither diabetes nor pre-diabetes at baseline, there's no difference between CPAP and usual care for incident of diabetes. Even the pre-diabetic patient who are on the left side did not change. I would say in this study, the number of patients who converted from pre-diabetic to diabetic was lower than what we expect from the general population. Maybe that affected the data, but for the purpose of the study, even a pre-diabetic patient, we did not decrease the incident diabetes in this population. At least the actual numbers, they're all statistically insignificant. The only statistically significant event were not really clinically relevant, because what they did is they decreased the fasting glucose in the normal patient, but the baseline number was normal to start with. So in reality, and the number was low, so clinically, despite this being statistically significant, it wasn't actually clinically relevant data. When they did analysis on this data, the only thing that came back positive, there is a female positive signal. So when they looked at the non-diabetic female and they looked at the CPAP versus no CPAP, there was a decrease by 18.6 milligram of per deciliter of glucose. So the fasting glucose did decrease in this population, and that's the only population they can find some data. Again, this is like a secondary analysis of this data. So no significant effect. Maybe there's something in diabetic women. That's all we have here. How about other trials? So we have this trial, the Aurora et al. Chest 2023. They used a continuous glucose monitoring. They thought is using fasting glucose, A1C, it kind of doesn't make sense because the glucose go up and down. We should look at the variable glucose changes rather than anything else. And it's basically also looking at CPAP versus control. And just to, so for time, because they thought that continuous glucose monitoring is actually more granular information because it's variable rather than just HA1C. It also came back negative actually, but there was also a positive result in women. So where do we go from here? There is a final study which I'm going to talk about before I end this talk. This is the chasteness trial. Again, discuss it by contrasted with the SAFE trial. So this is a type 2 diabetic specific trial who have OSA and diabetes versus the cardiovascular risk factor. They used sham CPAP versus just the usual care. It was double blinded. They tracked, and this is the most important part, which you're going to talk about the next slide. They tracked diabetic medication changes. They had a better CPAP adherence. So the safe CPAP, unfortunately, their adherence was 3.3 hours, but the mean CPAP adherence in this trial is 5, so much higher. So what did they find? The end result came back negative. When you go back, when you go late 12 weeks later, there is no difference. But if you notice here, the CPAP group, when you look at the mean HbA1c, it's improved. And actually at the 6-week to 12-week point, the data were actually statistically significant. And same thing, they stratified this by HbA1c above 7.5, so worse diabetes, let's say, also the same. So for some reason, unknown for now, that the A1C improved and the stage improved. What happened? The sham CPAP actually caught on, and this happened in both sides. So what happened? What's the problem? As I told you, they tracked medication, and this is what they found out. During the assessment, compared to the baseline, the people who are in sham had increased tightening of their glucose medication, and the people on the active arm have decreased their medication intensification. So we always have to forget there is like this in the background. There is this physician who's looking at this A1C and sugar and changing medication. So it's probably, if you look back to this data, now this is what infer from this data, that what happened is the CPAP maybe worked, maybe not, but those sham CPAP control group, they have a higher A1C somewhere here, and doctors actually intensified their glucose control, and that drove down their A1C. And those patients actually on the CPAP group are decrease their medication intensification, looking at the data I showed in the previous slide. So, you just have to keep in mind that when you do these trials, there's a chance that when you use your A1C and use your glucose as a outcome, there is a chance that there's other factors like medication. The physician that's treating this patient probably wasn't happy with those numbers and giving medication to increase it. So they think probably that's what drove it. But they also found out another signal where, sorry, where to go? There's each 1% a night of use of CPAP decrease A1C, and using it more than 7 hours a night have a meaningful, significant result of 0.54% with a positive p-value. I was going to say, thank you very much for listening, and if you have any question, please let me know.
All right, thanks, Karam. We'll look out for some questions. While we're waiting, uh, I was wondering, what you thought of we talked a lot about hypoxia, and certainly, it's flavored by my views of it as well. As far as the other mechanisms, do you think any of the other mechanisms play as much of a part, or play a
Yes.
part? Is there any data on that?
Of course, I believe there is data from the my study when they found that glucose actually, the
Mhm.
corticosteroid was increased on the both in the intermittent hypoxia group and the regular group. There's also studies about arousals and catecholamine surge. So clearly, these also have some kind of mechanism and affects dysglycemia. But but not all of them were basically put head to head with intermittent hypoxia. And the study, when you try to account for those other mechanisms, it looks like the intermittent hypoxia becomes the driving factor. So to sum it up, it seemed to me that the intermittent hypoxia is a bigger driving factor, and all the other mechanisms are there, but as a contributory effect rather than the main effect driver.
This is from Dr. Yagi. Is there fantastic talk, Karam. Is there any data examining hypoxic burden or delta HR response on outcomes in diabetes mellitus and effectiveness of CPAP in these subgroups?
It was not reported in the main. It was not reported in the main papers. I'm not sure if there's any stratification about T90 or the hypoxic burden of these studies. If anyone did a secondary stratification, but for the main presentation, I don't think they stratified this data. Even unfortunately, even in the ODI data, the Japanese data, when it was a basically they're looking at ODI severity and high incident diabetes, they did not report the result by hypoxic burden. And that would be a very interesting trial to have, specifically looking at the hypoxic burden, because we know it's a relationship with as a risk factor for CV cardiovascular risk factors.
Yeah, I haven't seen. Um, I haven't seen hypoxic burden data. There might be. Um, I would suspect. I think that's a really interesting question, and it's an easy study to do. If the in but you'd need the population to
Yeah.
that already had that data out there.
Unfortunately, like the SAFE trial was a nice trial. We're looking at CV risk factor. The mean CPAP adherence, as I said, was 3.3 hours. They ruled out the sleepy patient. They took out the extremely hypoxic patient, the nocturnal hypoxia, which again they defined with more than 10% of the night he's spending it less than 80% SpO2. So ideally would be some kind of a trial where we can have a good compliance, ideally more than 7 hours plus if possible, and look at those sleepy hypoxic patients with high hypoxic burden. That will be actually ideal trial to, because if we think the hypoxia is the main driver, that's probably we think hypotheses are going to fix their
Yeah,
improve their A1C or fasting glucose and maybe even incident diabetes, but I don't think that's ever been tried.
yeah. Another question from Dr. Rue. Great talk. It might be interesting to check whether REM-related OSA patients have a higher prevalence of diabetes, as usually glucose levels decrease during REM sleep, and hypoxia might be more severe during REM sleep. I'll actually comment on this one because this was a study that I had done in fellowship. I was convinced that REM-related apnea was going to be predictive of incident diabetes. We had done an analysis of the DREAM trial. It did not shake out. So at least in the data that we had done, and it's not this study. So this is another study that we had done, um, looking at predictors of incident diabetes and prediabetes. REM-related apnea was not associated, but I think they're probably that data is mixed when we look at the big picture, and I would suspect that the reason in that population it may have not shown to be positive is maybe they didn't have as much hypoxia. We didn't have that data, but it was the oxygenation that was really associated and not necessarily REM-related apnea.
Yeah, I was just going to share the slide because it kind of talked
Yeah.
about hypopnea, hypoxia, and there's a REM
Hmm.
hypoxia too. And after adjustment, the
Hmm.
REM hypoxia people end up, it
Hmm.
wasn't statistically significant. So,
Yeah.
this could be that the hypoxia itself, as you mentioned, maybe not specifically the REM hypoxia part.
Yeah. Yeah. But I actually had the same thought. We just haven't seen that the REM is the major contributor. I suspect it's more the hypoxia. All right. Well, I think we're kind of done with questions. Thank you, everyone. This is a great talk, Karam. I th- and thank you everyone for your attention. I think that's about it. Have a lovely day.